Hey there, everybody. We're getting ready to get started. Let me find my correct clickers. All righty. I hope everybody is having an amazing, what day is today? Thursday. It's kind of nasty outside here in Tennessee today, so I'm rather glad to be working. Let's see. Move that out of the way. There we go. Good afternoon, everybody, and welcome to today's presentation on crisis intervention and preventing suicide. This is based in part on the APA practice guidelines, and in your additional resources section of your class, there's the full text to it if you really want to look at it. But we're just going to, obviously, in a little over an hour, hit the highlights. So we're going to talk about how to estimate suicide risk. We spent quite a bit of time yesterday in legal issues talking about involuntary commitment, and one of the reasons people very often get involuntarily committed is because they are a suicide risk. So we're going to talk about how to estimate that. And we really have not found a foolproof way of doing so, which is why it is so important when you have a client who is suicidal or you think may be suicidal to consult, to make sure that you can document that another reasonable person with your levels of education and training would have made a similar decision. So if you consult, you can document that, and the decision was made to not involuntarily commit and the person does attempt suicide. You've got a little bit more legal recourse to protect yourself, saying none of us saw it coming. Factors altering the risk of suicide and attempted suicide. So we're going to look at things that we can do to prevent suicidal ideation and suicide, as well as if somebody is in crisis, what we can do to try to intervene. Additional considerations in specific treatment settings. So if somebody becomes suicidal or goes into crisis in residential or outpatient, what do we need to do? Strategies for enhancing motivation and promoting treatment engagement. When somebody is clinically depressed and they're to the point where they just don't feel like they can go on living, having them have motivation to do worksheets and journaling is tough. So we're going to talk about ways to increase that motivation. We'll talk about education points for the client and family, and risk management and documentation issues. So it's important to remember that all clients perceive events uniquely based on their history. What is traumatizing for one person may not be a big deal for another person. So you don't want to assume, as we talked about in trauma-informed care, that how a client is interpreting or reacting to an event. All clients participate in care that is respectful and non-judgmental in crisis intervention, because now's not the time for them to be feeling like they're judged or they're looked down upon, because they're already feeling vulnerable and threatened. Reflection and empathy is most effective. Let's just hear what the person has to say, because right now they're feeling out of control. They feel like they're spinning. So if they can bounce some things off of us, if we can empathize with how out of control they may be feeling right now, that gives them a sense that, okay, somebody kind of gets it. There might be some hope. Ego strength is a variable among individuals, and it's influenced by past experiences and social support. So who they are, what they want, if they're a good person, all those beliefs that they may have depends on the person. Some people have very little ego strength, and they're always chameleoning, trying to be what everybody else wants them to be in order to get approval. Their self-esteem is really low, etc. It's important that clients and families are actively involved in collaboration and decision making, because they want to feel, in crisis, it feels like everything's out of control, hopeless, helpless. When they start making progress, it's important for them to feel like they're in control of the process. They're developing that self-efficacy again. We want to remember that stress is a normal part of existence and can foster self-development and growth. And crisis, I have never met someone who hasn't at some point in their life gone through a crisis or 12. Things happen, and it can, throw you into sort of a proverbial tailspin for a few minutes, but it doesn't mean that you're broken. It means that you've hit a barrier where you've never had to do something like this before, or you've overwhelmed the skills that you do have. So you're going to have to be creative and grow and develop from it. People can go through hardships that they never knew they could handle. You ask them later, how did you get through that? And they're like, I never thought that I could manage something like that, and lo and behold, I did. And so we start talking about that growth that came out of it. And we need to remember that all clients are capable of assuming personal responsibility. And you may say, well, if somebody's in crisis, they may need to be involuntarily committed. Okay, maybe. But at some point, when they're in a frame of mind where they're thinking clearly and everything, they're capable of assuming personal responsibility 99% of the time, or much greater, actually, because 99 is 1 out of every 100, but much greater than that, 99.99% of the time. Even when clients are in crisis, they're thinking clearly enough to assume personal responsibility and say, yes, this is something I need, or no, this is not. All clients grow and change in an environment of acceptance, trust, and empathic understanding. So there's that humanistic thing coming out. But it's true. If we accept them and we trust that they know what's best for them, and we understand where they're coming from, we try to get into their head. And you're not going to understand exactly where they're coming from because you haven't been there. But we can accept that their point of view may be right. That whole dialectics thing, we both can have very valid points. So we want to accept that they have valid points, they have valid opinions, that we want them to feel validated. Sustained change occurs when clients feel ready and supported, and people have a need for self-mastery and control, which is why we need to bring them in and get them involved and say, all right, I'm sure you've gone through tough times before, or what do you think could help you at this moment? Instead of doing things to and for the person, asking them, all right, I need you to help me here because you're the expert on you. Help me see what it is I can do, what you need. Crises can be strewed as danger or opportunities for growth. So if we can help change the paradigm, instead of feeling hopeless, helpless, out of control, as one of a challenge that is the opportunity to grow, then it can be, a little bit more liberating and motivating to the person. Think about, when you went to take your GREs, your SATs, or any of those tests that you really can't study for. You can prep, but you can't study. It feels overwhelming. At least it did to me, because I was one of those people who likes to study, likes to know the answers. And going into those, I could have approached it like, oh my gosh, I have no idea what's going to be on this test, and I'm going to be completely overwhelmed and yada, da, da, da. But instead I said, I've done the test prep class. I've done everything I can do until now, with the skills and tools I have. Let's go see. I looked at it as a challenge to see how well I could do on something that wasn't the normal way I prepared for things. And you have to learn to take tests differently when you do the GRE and SAT and aptitude type tests. So, it's kind of the same thing on a much more impactful scale when we're talking about crises. Encouraging clients to look at what they have. Not, let's take a gratitude inventory right now. No, that wouldn't be sensitive or appropriate. But we can say, all right, your life is very chaotic right now. Your husband left, you lost your job, and you've got 3 kids, and you have no idea how you're going to pay the bills and yada yada. So the person's in crisis. Okay, who can you rely on? What social supports do you have? What financial stuff do you have? Savings accounts and stuff. What community resources are there to help you? Start making a list of all the strengths and resources that this person has, so they can go, oh, okay, I'm not feeling quite as out of control. There are options. Crisis intervention is an active process that focuses on the immediate problem. We're not talking about dealing with how she feels about how her spouse, walked out on her. We're talking about dealing with the immediate problem. She's concerned about providing for her children. Crisis intervention is time limited. Generally, crises don't last more than a few days or a week or so before the person, either starts to feel better or becomes suicidal, because, when they're really intense crises. Some crises can go on a little bit longer, but crisis intervention, you're really looking at, a month or less for crisis intervention services. Now, the person may still need counseling services after that to deal with some of their other stuff, but the presenting problem should be able to be on its way to being resolved in a month. Advocacy is essential. When somebody's in crisis, it's up to us to advocate for them with their family, with their, obviously with appropriate releases of information, yada, yada. But to help them in whatever way they need. So if we're seeing a client who's in crisis and, maybe they would benefit, or they think they would benefit from increasing their dose of antidepressants or something, and they want us to advocate for them with their physician in order to make that happen. Obviously it's going to be a clinical decision. If they're trying to get you to get the prescribing doctor to prescribe them, a whole bunch of medications for, that are addictive and stuff, and your spidey senses are going off going, I'm not sure that's really going to help the problem. But we can still advocate with the physician and provide him a written summary of kind of what's going on and how the client is right now and what the client thinks he or she needs, and then let the physician decide from there. But we can help serve as an intermediary. We can also help the client identify what it is that they need, because sometimes they don't even know. So we can just sit down and we can say, all right, let's just make a list here of the things that have helped in the past and what we might be able to do, because that stops all the spinning that's going on in their head and it puts it down on paper. Even if they're not visual learners, just putting it down on paper can very often help, because then it feels like they're getting grounded. And it can, as you pointed out, help the client feel validated when we advocate for them to say, you're not broken. You're struggling right now, but there are things that we can do. So let's work together, because they feel, I don't want to say like we're on their side, but they feel like what they're asking for is not unreasonable at that point. The focus is always on increasing the client's level of social, occupational, cognitive, and behavioral functioning. So socially, we want to increase their social support, wherever that is. If it's support groups or people they already have in their network, we'll talk about that. Because in a crisis, people need more support. And it can be assistance with their kids, because sometimes, if you have a child that's in the hospital and you have other children at home, you're going to be stressed out about that child that's sick, but then you're going to need help with the kids that are at home. If, something happens and, the caregiver is just clinically depressed and in crisis, they may not have the energy and ability to think through the process of cooking meals and stuff for a little while. I mean, we see this when people are grieving in that initial grief process. What do we do for wakes and stuff? We bring over casseroles. We say, you know what? We know that you don't have the energy to cook right now. So we're going to help them focus on what their social supports are, but also what resources are in the community that can help them. Occupationally, help them with figuring out how to take time off from work if they need to, how to get through work if they can't take time off. How can you just kind of get through the process, or whatever they need. Cognitively, we're going to help them look at the situation maybe from a broader perspective, open up that tunnel vision. And behavioral functioning, looking at what can you do that's going to help you feel better, what can you do that, or what do you want to avoid that might make you feel worse, such as drinking or not sleeping or whatever. 10-step trauma management protocol. Wouldn't it be great if it were that easy? Just 10 steps, bing, bang, boom, they're done. But it's not. So the first thing we want to do is assess for danger to safety for self and others. This means the victim, us, the counselors, and anybody else who may have been affected by the trauma. So if there's a trauma that happens, you want to see where this person is. And we'll use the school shootings as an example because, it's a trauma everybody's talking about right now. For each client that we're talking to, each person that was in that school or related to someone in that school, we want to assess for danger for self and others. Are they feeling hopeless, helpless, out of control, defeated? What about, obviously, if there were the victims of a trauma, any of them who were actually in there, we want to assess how they're doing. We also want to assess the counselors that are talking to the victims for vicarious trauma. And, we want to look at all aspects, anybody who's touched by this trauma, how are they doing? Consider the physical, emotional, and perceptual mechanisms of the injury. Physical mechanisms, obviously, if the person was punched, raped, shot, whatever. Emotional, how did it make them feel unsafe, out of control, angry, any of those dysphoric emotions. And even remember, in trauma, you can have some people who come out of it and feel elated because they kind of got through. It's that rush of adrenaline, like, oh my gosh, I survived. And then they may feel guilty because they felt elated. So we got to look at all that stuff. And perceptual mechanisms, how did it change how they perceive the world, their safety, the goodness of other people, the environment, all that kind of stuff. So cognitive, emotional, and physical. The victim's level of responsiveness should be evaluated, or the person in crisis, their level of responsiveness should be evaluated to see, are they here or are they in, denial? And I'm not talking about Egypt. Because sometimes right after a trauma, people just kind of shut down and they're physically there, but they're in such a state of shock that they're not really responsive right now. Address any medical needs. If the person's in crisis or if there was a trauma, make sure that they are medically stable. And that can include if, anybody, if it's a trauma situation like the shooting, any of the survivors that came out, making sure that they have enough food and water, and anybody who's diabetic is getting their insulin tested and making sure that stays stable and they're staying medically stable. I mean, they're not going to be great after a trauma, but we want to make sure they stay stable and we don't have other things, because stress makes blood sugar go all over the place. High blood pressure can also be elevated, so check the teachers for high blood pressure. Identify signs of traumatic stress after a trauma, or if you're dealing with someone in crisis, again, look for signs of traumatic stress, maybe a trauma that happened that is now prompting this current crisis. Connect with the individual by developing rapport. Go figure. Build rapport by allowing the client or person to tell their story. Help me understand what's going on here. Instead of going in and going, all right, I need you to, you've got to, that's taking all their power away. If you can start out with, help me understand what's going on here. Now, sometimes you need to set some limits ahead of time to make everybody, a little bit safer. If there's, when there were fights on the day room, in the day room. I would have to say, all right, I need everybody to go to their rooms right now or sit down or whatever the case was. And then I would say, this person, you need to go with that therapist. Why don't you come with me? Let's go take a walk and let me understand what's going on, because I wasn't there. Fill me in. And so we're not taking their power away. We're not trying to fix the situation, but it's, getting everybody safe and into a place where we can start, as interveners, can start understanding what's going on. If a client's in your office, obviously you just have to say, all right, help me understand. Provide support through active and empathic listening. No judgment here. It was a crappy situation or whatever. Let me just hear. Normalize, validate, and educate individuals' emotions, stress, and adaptive coping styles. So I can't imagine what it's like to be going through this like you are. Normalize the emotions they're feeling, from anger to guilt to relief to whatever it is. Help them understand what normal stress reactions are going to look like, or traditional stress reactions are going to look like after a crisis or a trauma, so they can go, okay, this is not unexpected. When people are in crisis, the worst thing that can happen, or one of the worst things that can happen, is for the unexpected to happen. So if we can say, you may not experience any of these symptoms, but let me tell you what might happen, just so you're not caught off guard, it helps them feel more in control. And we'll talk about adaptive coping styles. What you're doing right now, crying, asking for help, is not a sign of weakness. It's a sign that you're trying to survive. After the trauma, maybe the trauma happened a year ago or something, and the person started drinking, or we'll just use that because that's a really common example. And instead of pathologizing it, we can say, you had to figure out how to make the pain stop somehow, and nothing else was working. Now you're trying to look for other options, or now the alcohol is not working either, and you're feeling just at the end of the road. And then go from there. Bring the person to the present. Describe future events and provide referrals as needed. So we want to talk about, what is it that you need right now? I understand all this stuff that happened yesterday or last week or over the past 6 months. They've told us that story, and that's a lot to deal with. So, what is it that at this very moment you're needing? In the next 24 hours, what is it that you might need? Do you have kids that need to be tended, a dog that needs to be walked, plants that need to be watered? Have them talk about some of that stuff that's normal for their daily life. Tell me what your normal day looks like, so we can figure out, if they're going, well, I don't know what I need. Okay, what does your average day look like? You get up in the morning, what do? Walk them through that so you can figure out if there are dogs, kids, significant others, a job that needs to be alerted, etc. And then you can start saying, all right, now how are we going to handle all this? Which means you're talking about making future plans. If somebody's willing to make future plans, that is always a good sign. It isn't a be-all, end-all, but it's a good sign. The safer model, and I added the extra R. Stabilize. Obviously, if somebody's in crisis, they're not thinking as clearly. They feel like, they're spinning, a fish out of water. They can use different metaphors, but we want to help them feel like they're stable, like they can stand, like their legs aren't going to fall out from under them. Acknowledge what's going on. No judgment, just let me understand what's going on and acknowledge how tough that is. Facilitate understanding of, you need to understand what's going on with them, but they may also need some understanding of what's going on with them, so they understand why they're having these reactions and they understand what to expect. Encourage adaptive coping. So we're going to look at what are the problems you're identifying and what are the logical steps you can take. Restore functioning. Help them see, we were talking about that daily routine. How can you start getting back into that daily routine? You may not be 100%. So what are the minimum things you need to do? I know when I was recovering from surgery, it felt like it took forever and I wasn't 100% and it drove me nuts. But I had to figure out, okay, now, given the amount of energy I have right now, what needs to be done and help them. I restored functioning a little bit. And as I got more energy, I added more things back to my daily routine. And then refer. Once you have them stabilized, what's going on. Most people in crisis are going to need some assistance. And, most people, period, need some assistance. Most of us don't do everything all by ourselves all the time. So make sure they know what resources are out there if they need to tap into them. Prevention's always the best, and primary prevention keeps the problem from ever happening. So we would avoid trauma. Nobody'd ever be traumatized, and we'd avoid anything that would precipitate a crisis. Well, that doesn't happen, but we can do things to prevent as much trauma as possible. We can do things, for example, to make schools safer. We can do things to make it so people feel safe going to the store and other things. We can do things to make people feel safe in their neighborhood. So that's primary prevention. Secondary prevention prevents the problem from causing other problems. Okay, there's a trauma. Let's help the person deal with it so they don't also start developing, generalized anxiety with agoraphobia and substance abuse issues. So secondary prevention says, all right, we've got this. Let's keep it from getting any worse. It's like when you get a cut. A cut is one thing. If you let it fester, if you don't address it, then it could turn septic, and then it starts affecting all of your organs. So, and obviously that's way down the line. But you want to prevent it from causing other issues. Tertiary prevention is preventing the problem from getting any worse. All right, we've got this problem. The person was just diagnosed with HIV, or the person, has clinical depression or is in crisis. All right, well, they're in crisis right now. Let's prevent it from becoming a situation where they may be feeling suicidal. In a suicide assessment, obtain information about the patient's psychiatric and other medical history and current mental state. Now, this is when, ideally, you've already done the rapport building and everything, and you're actually doing a formal assessment for treatment at this point. You're going to identify specific psychiatric signs and symptoms. Go through your depression and your anxiety checklists. Look for signs of bipolar disorder, psychotic features. Assess past suicidal behavior, including intent of self-injurious acts. Intent. Some people injure themselves for reasons other than trying to die. And so it's important to understand what was the intent when you did that. Some people accidentally overdose on drugs, and they weren't intending to die. They just, accidentally overdosed. Review past treatment history and treatment relationships to figure out what have you done, what's worked, what hasn't. Are there any treatment relationships or people we can hook you back up with? And identify the family history of suicide, mental illness, and dysfunction, because then you're going to be able to identify some of the contributing factors potentially to the current crisis, but also some of the restorative factors. If you have a parent who has a mental illness, how did they deal with it? What things helped them? So that may give us some clues. Address the patient's immediate safety and determine the most appropriate setting for treatment. So this is a suicide assessment. This isn't crisis intervention now. We're up to, the patient has some suicidal ideation. We just don't know where they are on the spectrum at this point. Develop a biopsychosocial differential diagnosis to further guide the planning of treatment. Remember, suicide assessment scales lack the predictive validity necessary for use in routine clinical practice. So that is the long disclaimer that's in there that says you can use these scales to see how suicidal somebody potentially is, but their reliability and ability to accurately predict who's going to attempt suicide and who's not, pretty low, because you can have two people who have similar levels of suicidal ideation, and one may attempt and the other one may not, and we just don't know how to figure out. Identify specific factors and features that may generally increase or decrease risk for suicide or other suicidal behaviors, and that may serve as modifiable targets. So, social support network. Is it good? If it's good, it can mitigate the suicidal ideation. We might be able to pull that in, and who can help you. If the social support network is one of the main causes of the distress at this point, then we're going to try to figure out other workarounds where we can help them get social support, but it may not be from their primary network right now. Cultural religious beliefs, particularly as they relate to death or suicide. Some religions and cultures see suicide as an honorable thing to do to prevent shame from coming to the family. Other cultures see suicide as a unforgivable sin. So, looking at cultural religious beliefs. Now, you've got to remember, culturally responsive approach helps us understand that just because I happen to be a white female Catholic doesn't necessarily mean I embrace white female Catholic principles. I have certain ethnicities and cultures that I associate with, but it doesn't mean that I have embraced those values. So you don't want to assume that because someone is a certain ethnicity or religion or whatever, that they necessarily embrace the values of that culture. Nature, frequency, depth, timing, and persistence of suicidal ideation. So if their suicidal ideation, happens once a year, not very often, it comes, a person feels suicidal for a day or two, and then it goes. That's different than someone who feels suicidal 7 times a month, and it's really intense. The depth of the suicidality is also important. Are they having ideas about it, or do they have a plan and they have the means and everything's kind of good to go? So we want to figure out where they are. The timing, sometimes the timing corresponds to certain holidays. Sometimes it is, maybe when somebody is alone, at night, they get suicidal. During the day, they're doing fine. They're busy, they're at work, whatever. At night, they go home, they start to think, they get kind of trapped in their own head, and they become suicidal. So all these things are things we're going to think about. And if for that person, we're going to say, how can we help you in the evening? First thing I would think of is there somebody you can stay with for a little while so you're not alone at night and you have somebody you can rely on? If not, let's look for hotlines. Let's look for people that you can call who are willing to pick up the phone. Anything that can help you kind of get out of your own head. If ideation's present, you want to know more detail about the plans. How are you going to do it? Do you have the means? Yada, yada. And remember, if they plan on doing it one way and they don't have the means, and something exacerbates their suicidality and they decide, I'm going to do it, they may choose a different method. So don't assume that just because they said they were going to commit suicide this way and they don't have access to that means right now, don't assume that means you're free and clear. Identify the current psychosocial situation and the nature of the crisis. Get a broad picture of what's going on, and appreciate the psychological strengths and vulnerabilities of the individual patient. So, maybe one of their vulnerabilities is they worry about everything, and they're stressed out and tend to go from 0 to 220 in 2.3 seconds. Okay, that's a vulnerability, but one of their strengths is they persevere. One of their strengths is they're really smart. One of their strengths, you can build on those strengths too. So we're recognizing that nobody's perfect, but let's look at their strengths and how can we use these strengths to deal with or mitigate the vulnerabilities. So if somebody's really smart, sometimes they can use cognitive behavioral interventions to deal and I don't want to say just people who are really smart, but if somebody's intelligent, they can use cognitive behavioral interventions to deal with, persistent anxiety. They can use thought stopping. There are techniques that they can use. So we want to help people see, let's use this strength, and we're helping them see that they're pulling from stuff they already have within themselves to deal with this other issue. Begin with questions that address the patient's feelings about living, such as, how does life seem to you at this point? Now, I probably wouldn't choose that one necessarily at the beginning. For me, I tend to start out with, more rapport building, and then move into things like, have you ever felt like life wasn't worth living? Or do you ever wish you could go to sleep and not just wake up? I've never been comfortable starting out with those kinds of questions, though, because I feel like people would be going, well, no, because that catches them off guard, and they may be afraid that they're going to be involuntarily committed. So, I try to establish rapport, and then we start talking about some of these questions. Focus on the nature, frequency, extent, and timing of the suicidal thoughts and the interpersonal, situational, and symptomatic context in which they are occurring. Interpersonal, we've kind of talked about, are they alone? Are they with friends? Are their friends making it worse? Yada, yada. What's the situation? Did something recently change in their life that's precipitating this crisis? A diagnosis of a terminal illness, or who knows? So there could be a situation that's precipitating it. It could be the situation of a holiday anniversary that is reminding them of a trauma and precipitating it. And what is the symptomatic context? What are their symptoms? What's going on? Are they feeling agitated, restless, insomnia, wanting to sleep all the time? Is it occurring in concert with, maybe a persistent depressive disorder or generalized anxiety? Because that's really going to impact the types of interventions that you might be looking for. Inquire about suicidal thoughts. Elicit the presence or absence of a plan. If the patient doesn't report a plan, ask whether there are certain conditions under which they would consider suicide, which, that's something that I typically haven't done, that I was reminded of when I did this presentation. Okay, you don't have a plan, but could that change, basically? So we want to have them think about it. And no, we're not pressing them, and that's not going to trigger them to get there. That's us saying, let's plan, ahead of time so we can put safeguards in place. So what might push you to the point where you would consider suicide? All right, let's make sure that doesn't happen. Whether or not a plan is present, if the patient has acknowledged suicidal ideation, there should be a specific inquiry about the presence or absence of a firearm. Men typically use firearms more than women, but it doesn't mean that women won't use them. And firearms are probably one of the most common methods. There's also hanging, but some people avoid hanging because that sounds painful and they just want it to be over with quickly. But firearms, and I also ask about pills in the house, especially opiate type pills. If the patient has access to a firearm, recommend to him that a significant other restricts access to this, so they get rid of it somehow. They either put it in a safe and have their spouse change the lock so they can't get into the safe. They give it to a friend. Same thing for medications that could be used to overdose. I encourage patients, if they've got benzos or opiates in the house, that they're not taking, or even if they have them in the house, I encourage them to have somebody else kind of in charge of them if they think that might be a risk factor. And then if they're supposed to be taking them, then that person gives them, a certain number each day so they have enough to get them through the day. And that's actually how we deal with a lot of people when they first get out of substance abuse treatment too. If they're prescribed certain medications like benzos, who can help you monitor your medication? And then we wean off to where, we're just doing pill counting every week when they come in and yada, yada. But anyway, getting somebody involved that's going to help protect the person from the most lethal means. Document in the medical record, being sure to include any instructions that have been given to the patient and significant others about firearms, other weapons that can include, knives, machetes, whatever they use to hunt with. And I also include medications in there for myself when I do it. Assess the degree of suicidality, including intent and lethality of the plan. That'll give you a general idea. Now remember, some people can have thought about it. They can have actually created the whole plan in their head, but they may not have that intent. They see it as this out that's kind of out there, but their intent is low. But you also have other people who, when they get to the point of thinking it out, have 100% intent. And remember, if their mood changes, if they're depressed, really depressed, really upset one week, and then they come in and they seem to be doing a little bit better, don't take that to mean necessarily that they're doing better. That could be they've just made the decision that they're going to commit suicide. So you still want to keep, paying attention, intervening, being alert to what's going on. Sometimes when people are in crisis or really depressed, they don't have the energy. And when they start getting that energy back is when, they decide to take the steps to kill themselves. So be cognizant of that. Between age 10 and 24, doesn't that break your heart? Between the ages of 10 and 24, and over 70 years are the critical periods. These are the highest. I've told you yesterday that the risk of suicide was bimodal. So young people and older adults tend to be at higher risk. Thoughts of death are more common in older adults, but as people age, they're less likely to endorse suicide. So, a lot of times they're just like, they come to peace with whatever it is and decide when it's their time, it's their time. Self-destructive acts by older people do tend to be more lethal, though. The greater the lethality is the function of several factors. Reduced physical resilience, and this is in older adults. Reduced physical resilience, greater social isolation, and greater determination to die. So if they're starting to have a lot of physical health problems, and if maybe their spouse just died or what have you, they may have a stronger determination to die. So we want to look at all those things in older adults. What's changing? Suicidal elders give fewer warnings. A lot of times, there are very few warnings. There are warnings, but there are very few most of the time. Gender. Death by suicide is more than 4 times as frequent in men and women. Men are less likely to seek and accept help for treatment. We still have that stigma going on. And a lot of men perceive treatment to be, warm and fuzzy and crying in tissues and talking about feelings. And some men are not comfortable with that. And one of the things that I emphasize when I work with some of my clients, especially when I do presentations to first responder units, is that there is cognitive behavioral. We can talk about very practical, very active things. We don't have to get down into, that emotionally charged stuff necessarily. And that seeking help is not a sign of weakness. It's a sign that, you don't know how to do something. You had to have somebody teach you how to fill in the blank, drive a car, shoot a gun, whatever it is. And so sometimes you need somebody to help teach you how to deal with things that are overwhelming, that overwhelm those skills that you currently have. Women have several protective factors, tend to have lower rates of alcohol and substance abuse, although that's starting to change. Less impulsivity. I was surprised by that. More socially embedded. And as women, typically, and this isn't true of all women by any means, but a lot of times women have more friends. They have, friends in the community, and they have people they can rely on. Not everybody. So, you want to not assume that just because it's a female that she's got 5 girlfriends she can call, because that may not be the case. Women do tend to be more willing to seek help, though. Women have higher rates of depression and respond to unemployment with greater and longer lasting increases in suicide rates than men. So I thought that was another interesting fact. So when women become unemployed, their suicide risk goes up. Women who are pregnant or have young children are less likely to kill themselves. So yes, we have those bad media played up incidents of postpartum depression, but in general, women who are pregnant or who have children don't want to leave those children. Rates of suicidal ideation and attempts are also increased in individuals with borderline personality disorder and those with a history of domestic violence and physical and/or sexual abuse. Talking to the client, getting to know, what their abuse history is, what their trauma history is, if they've got borderline characteristics, or, substance abuse is not listed here, but a lot of people, when they are in active addiction, have characteristics that are very similar to borderline personality disorder. And so if you've got those characteristics going on, they tend to be at more risk. Suicide in whites and non-Hispanics are approximately twice those observed in Hispanics, non-Hispanic African Americans, and Asian Pacific Islanders. So white non-Hispanics tend to be the ones that are at higher risk. For immigrant groups in general, suicide rates tend to mirror the rates in the country of origin, but converge toward the rate in the host country over time. So if there were high suicide rates in the country of origin and there are lower suicide rates here, the longer they're in the country, theoretically, the lower their risk of suicide. Racial and ethnic differences in culture, religious beliefs, and societal position may influence the rates and values about suicide. In some cultures, like I said earlier, shame can be considered a traditionally accepted way of dealing with shame, distress, or physical illness. So knowledge of and sensitivity to common contributors to suicide in different racial and ethnic groups, as well as cultural differences in beliefs about death and suicide, are really important for every mental health counselor, because you've got people who come in who may be biracial, who may, be of a certain race or culture, and you need to have that knowledge ahead of time. The suicide rate of single people is twice that of those who are married, despite what the memes on Facebook would tell you. Divorced, separated, or widowed individuals have rates 4 to 5 times higher than married individuals. So considering, what does being divorced, separated, or widowed mean to this person? And you can see where their suicide risk might go up. The presence of another person in the household also may serve as a protective factor by decreasing social isolation, engendering a sense of responsibility towards others, and increasing the likelihood of discovery after a suicide attempt. So if somebody slits their wrists or overdoses, they may be found in time to be rescued and revived. So encouraging people not to be alone when at all possible. The presence of a high conflict or violent marriage can be a precipitant rather than a protective factor of suicide. That's not a shock. Major psychiatric symptoms. More than 90% of people who die from suicide satisfy the criteria for one or more psychiatric disorders. So, this statistic kind of can be used against the people with mental health issues are not dangerous. But you've got to remember, it's not either or whatever you want to say. There are millions of people that have diagnosable mental illnesses. There are not millions of people that commit suicide. But of the people who do try to commit suicide, 90% of them qualify for one or more psychiatric disorders. So of the 100,000 people that try to commit suicide each year, they also will likely have a psychiatric disorder. But the proportion of people with mental health issues that commit violent acts is really very small. Patients with mood disorders who died by suicide were more likely to have panic attacks, severe anxiety, diminished concentration, global insomnia, so they just can't sleep, moderate alcohol abuse, severe loss of pleasure or interest in activities. Let me say something about global insomnia, though, because I have read some studies that have indicated that people who have insomnia that are able to get to sleep, but they wake up at 12 or 1 in the morning and they're alone with their thoughts, may be at greater risk than somebody who, has difficulty falling asleep. So if they can't sleep at all, or if they can't stay asleep, they're at risk. Suicidal ideation and a history of suicide attempts also augments risk. If you've already crossed that line, you're going to be a little bit more likely, I guess, if you will, to cross that line again. Comorbid and if somebody's attempted suicide before, then you have an idea that their culture and spiritual principles or whatever don't necessarily admonish it. We don't know if it advocates for it or not, but so you can't, that there are some of the things that might prevent other people from committing suicide aren't necessarily going to prevent this person. Comorbid anxiety, alcohol use, and substance abuse are common in patients with mood disorders. Suicide in patients with schizophrenia is about 8.5-fold higher than those without schizophrenia. In schizophrenia or schizoaffective disorder, psychotic symptoms are often present during a suicide attempt. It doesn't mean necessarily that they're having command hallucinations, but they can be psychotic. Command hallucinations account for a relatively small percentage of suicides. Patients with schizoaffective disorder appear to be at greater risk for suicide than those with schizophrenia. I'm going to let that sink in for a second. Patients with schizoaffective disorder are at a greater risk than those with schizophrenia. And suicide risk is increased in those who recognize a loss of previous abilities and are pessimistic about treatment. So if they, we know that schizophrenia typically doesn't happen until later in life, in the 20s, late 20s. So they may have had a great college career and be, on their current career, and now they're going, oh my gosh, I don't know that this will help. I don't want to be, I don't want to be schizophrenic, if they don't have a lot of hope that treatment's going to help. Abuse of substances, including alcohol, may be the second most frequent psychiatric precursor to suicide. And I don't know the answer to that question about whether paranoid schizophrenics tend to commit suicide more or less than others, but I will look it up for you. Alcohol abuse or dependence is present in 25 to 50% of those who die by suicide. Impending interpersonal losses and comorbid psychiatric disorders have been specifically linked to suicide in alcoholic individuals. So you've got somebody who is struggling, with interpersonal losses and comorbid psychiatric issues, then they drink alcohol, which is a disinhibitor. It takes down those inhibitions, and they're just like, well, I can do this. The normal filter that would say, no, we're not going there, may not be quite as prevalent. Full-time employment is a protective factor in alcoholics, and the majority of people who are alcoholic or alcohol dependent actually are employed. So, that's not a surprising statement. Individuals with personality disorders have an estimated 7-time increased risk for suicide, especially borderline, antisocial, avoidant, and schizoid personality disorders. Personality disorders exist in approximately 30 to 40% of those who attempt to or die by suicide. So not only are we looking at mood issues, we're also looking at personality disorder symptoms, at least. So risk factors. Factors that increase suicide risk include communications of suicidal intent. All right, if they said they're going to do it, let's take them seriously, even if they have said it before. Prior suicide attempts. So if they've had prior suicide attempts, we need to be on guard a little bit more for future suicide attempts. Continued or heavier drinking, recent unemployment and living alone, poor social support, legal and financial difficulties, serious medical or mental illness, personality disturbance, or other substance use. I don't think any of these criteria are going to surprise you. If you have someone who's struggling, they're going to be at a greater suicide risk than somebody who's not. And so we've got to look biopsychosocially. Is there pain? Are there physical conditions that are contributing to it, etc.? Suicide's multiple motivations. We don't know why people do it. There are some theories it's anger turned inward, or a wish of death toward others that's redirected toward the self. That's obviously more psychoanalytic in nature. And revenge, reunion, or rebirth. Some people, when they kill themselves, are trying to get back at someone else. Some people, when they kill themselves, they can't take it anymore. Some people, when they kill themselves, are doing it because they don't want to be a burden to others. And there's probably a million other reasons, but those are three big categories. Suicide is rooted in a triad of motivations: the wish to die, I can't take it anymore; the wish to kill, I can't take you anymore; and the wish to be killed, I wish somebody would make it go away. Suicidal behavior has been associated with poor object relations and the inability to maintain stable, accurate, and emotionally balanced memories of the people in one's life. So thinking about the person, for example, with borderline personality disorder, where it's all or nothing. They either love you or they hate you. It's very unstable concepts of different people. Other important psychodynamic concepts are shame, worthlessness, and impaired self-esteem. So inpatient settings, we talked about how to handle it in different settings. Patients may be in the midst of an acute suicidal crisis or display the symptoms and disorders that typically lead to psychiatric hospitalization or increased suicide risk. So if they're in inpatient settings, we need to know that they're already obviously struggling for some reason. And just because they're an inpatient, don't think that they're safe. Don't think that says, all right, the pressure's off, they're not going to become suicidal. They can still decompensate. There do not appear to be specific risk factors unique to the inpatient setting. More than half of the patients who die by suicide in the hospital were admitted without suicidal ideation. So more than half of them came in, they weren't suicidal, but at some point during that treatment episode, they did become suicidal. It's important to remember. Now, whether they were triggered from trauma or whatever caused them to decompensate further, it's important to recognize that it's a high percentage. Extreme agitation or anxiety or a rapidly fluctuating course is common before suicide, and each suicidal crisis must be treated as new with each admission and assessed accordingly. Let's see. And in inpatient settings, we're talking about both psychiatric inpatient, where they're involuntarily committed, or voluntarily committed. Generally, when that happens, they're already espousing some suicidal ideation or homicidal ideation if they're involuntarily committed, or they're on a crisis stabilization unit. But what we're talking about specifically here is a normal admit for a residential unit for something. More than 50% of patients become suicidal after they've been admitted. In outpatient settings, suicidality may wax and wane in the course of treatment. Sudden changes in clinical status may include worsening or unexpected improvements in reported symptoms, and that requires that suicidality be reconsidered. So remember, I said people may start acting like they're feeling better, and they may actually start feeling like the fog is lifting. But when that fog lifts, they may see what they think is the forest for the trees, which is hopelessness, and decide, you know what? No, and become suicidal and make that decision. And then they're at peace with it, and they start tidying up affairs and saying their goodbyes and doing that stuff. Risk may also be increased by a lack of a reliable therapeutic alliance, a patient's unwillingness to engage in psychotherapy or adhere to medication treatment, and inadequate family or social supports. And remember, it's family as the client defines it. not necessarily family as you define it. So we want to just talk about social supports. In jail and correctional facilities, suicide is one of the leading causes of death. Persons who die by suicide in jails tend to be young, white, single, and intoxicated. Suicide in correctional facilities generally occurs by hanging, and isolation may increase suicide in these places. So if somebody is in jail and their family's not coming to visit them and they feel like, nobody understands them, especially if they've never been in jail before, the fear, the anxiety, the dread of, what they're facing and everything can contribute. Suicidal behaviors increase. If you're in a correctional facility, this is one of those things to pay attention to. Immediately upon entry, oh crap, what did I just do? I ruined my life. After new legal complications with the inmate's case, like a denial of parole, a sense of hopelessness and helplessness may set in. After inmates receive bad news about loved ones, that could happen to anybody. And after sexual assault or another trauma. Suicidal patients can activate our own latent emotions about death and suicide, so we need to know how we feel about it. Countertransference, we may have some feelings of hate and anger at suicidal patients and avoid patients who bring up anxieties around suicide. We may see patients who seem to be somewhat suicidal and go, no, I'm not dealing with that person, or that's going to be too difficult. Or we could have, more guttural emotional reactions to it that we need to pay attention to because we're probably reacting to the suicidality, not the patient, and get that in check. Seek consultation, seek supervision. Overestimating the patient's capabilities creates unrealistic and overwhelming expectations for the patient. Be aware of becoming enveloped by the patient's sense of hopelessness and despair, then responding by becoming discouraged about the progress of treatment and the patient's capacity to improve. There's going to be, very, very small steps, and it can be 2 steps forward and 1.5 back. But we want to see, what we're looking for is the patient still surviving and, a little bit better. And it can be very, very incremental, but we want to focus on that. And yes, guards need to be cognizant of suicidality and mental health issues in jails, and families, they may have very good reasons for not visiting their loved ones in jail or in prison or whatever. However, when we see someone who never has visitors, that's a risk factor. So ideally, it should send up the warning flags for the jail staff. Choice of specific treatment setting depends on the estimate of the patient's current risk to self or others, their medical and psychiatric comorbidity. So psychiatric, we know that if they're clinically depressed, we're going to probably put them in a higher level of care than if this suicidality is brought on by some sort of proximal precipitating event. But, it may not be any less lethal. So we want to pay attention to that. But we got to remember medical. If they're dealing with fibromyalgia, for example, I've worked with patients with fibromyalgia that just, they wake up in the morning and they don't want to get out of bed. They're just like, it hurts too much. I hurt all the time. I don't want to go on like this. And that's not necessarily a mood issue as much as a pain issue. Or if somebody's diagnosed with a terminal illness or a chronic illness, that can contribute to suicidality. We want to look at the strength and the availability of the psychosocial support network, the one that have, and are they willing to reach out? Are they willing to go to support groups? Are they willing to, connect with other people who could be helpful to them? And their ability to provide adequate self-care, give reliable feedback, and cooperate with treatment. So, can they do what they need to do on a daily basis? If not, then we need to consider residential. Benefits of intensive interventions must be weighed against their possible negative effects, such as having the person feel like they've lost their independence, the stigma associated with going into residential, the issue of, I've got kids that, I need somebody to take care of, the impact it will have on their finances, the impact it may have on their job. There are a lot of impacts that are going to happen if Jim Bob is suddenly not there for 30-60 days. Suicide prevention contracts, or the no harm contracts, are not a substitute for clinical assessment. The patient's willingness or reluctance to enter into an oral or written suicide prevention contract shouldn't be viewed as an absolute indicator of suitability for discharge. So if they say that, yeah, I'll sign that, no problem, that doesn't mean that they believe it. Not recommended for use with patients who are agitated, psychotic, impulsive, or under the influence of any substance. If they're dependent on established, they need to be dependent on established physician-patient relationship. So if you don't have a good relationship with that person, you're not going to be able to judge their truthfulness in signing it. But if I'm working with somebody that I've never met before and they say, will you sign this? Okay, fine. If it'll get me out of here, I'll sign it. But if I'm working with my primary or something, I might go, you know what, doc, let's be honest here. And suicide prevention contracts are not recommended for use in emergency settings or with newly admitted or unknown patients, because again, they'll sign anything if they really want to get out of that situation. Somatic interventions, benzos, treat symptoms such as insomnia, agitation, panic attacks, or anxiety. Long-acting agents are often preferred over short-acting agents. Now, when people take benzos, some people have the effect that as it starts to get out of the system, they may have rebound panic, which they may feel is even worse than just not taking it at all. So monitor. The benefits of benzos should be weighed against the occasional tendency to produce disinhibition, taking off those inhibitions to hurt themselves, their potential for interactions with other sedatives, and their potential for abuse and addiction. Benzos being discontinued after prolonged use should be reduced gradually and the patient monitored for increased symptoms of anxiety, agitation, depression, or suicidality. Benzodiazepine withdrawal is one of those that needs to be monitored, medically monitored. It's not safe for people to just quit cold turkey. And they can have significant anxiety as well as changes in blood pressure and heart rate and stuff if they are discontinued too quick. Antidepressants. There is an evidence for a lowering of suicide rates with antidepressants, but it's inconclusive. So there's some studies that say yes, some studies that say no, some studies that say it increases suicidal ideation. Antidepressant effects may not be observed for days or weeks. We say 30 days to 6 weeks to really get in the system. Patients should be monitored closely early in treatment and educated about this probable delay in symptom relief. Some docs will prescribe something that's a little shorter acting while the SSRIs are kicking in. I've seen Klonopin prescribed a lot, not so much Valium and Xanax, more Klonopin than those two, and I've seen buspirone prescribed a fair amount as well. Other calming medications include trazodone, low doses of some second-generation antipsychotics, and some anticonvulsants such as gabapentin. Lithium is, there's a lot of side effects to lithium, but in some cases, it may be the only option. The long-term maintenance treatment is associated with major reductions in the suicide risk in patients with bipolar and recurrent major depressive disorder. So you have to weigh the benefits versus the side effects. Still requires frequent blood testing, and there are certain foods people can't eat, etc. ECT is effective in patients with severe depressive illnesses with or without psychotic features, and is often associated with a rapid and robust antidepressant response. A lot of people think about the old ECT and it terrifies the snot out of them, so they don't want to go anywhere near it. So educating them about what it looks like, what it feels like, what it will do is important, and then they can make an educated decision. It may be recommended as a treatment for severe episodes of major depression that are accompanied by suicidal ideation. And ECT may also be indicated for suicidal individuals during pregnancy and for those who have already failed to tolerate or respond to oral medications. Clozapine is associated with a significant decrease in rates of suicide attempts for individuals with schizophrenia or schizoaffective disorder. It should be given serious consideration for psychotic patients with frequent suicidal ideation. So there are a lot of different things that you might see the doc prescribe, and if the patient doesn't seem to be improving, they're having multiple episodes, remembering these things and advocating for the client as needed. In order to promote treatment compliance, we need to remember that while they're symptomatic, while they're in crisis, right after a trauma, they may be poorly motivated to do the stuff that you're asking them to do, because they're just like, I can't handle life right now, let alone one more thing you're asking me to do. What are you thinking about? They may be less able to care for themselves. So making sure that they're remembering to eat. It's not like they're, incapacitated, but sometimes they need to be prompted to eat. They may need somebody to, help them remember to take their medication. Some people with really bad depression, really severe clinical depression, may just not have the energy to get up and take a bath, so they may need somebody to encourage them to do it. They may be unduly pessimistic about their chances of recovery, so we want to educate, cheerlead, keep baseline data so we can show them those incremental improvements. They may suffer from memory deficits or psychosis. Especially the memory deficits, have them write things down so they remember when they took their medication, they remember when they ate last, etc. And you can just do check sheets. It doesn't have to be this big long thing. If they're experiencing psychotic features, obviously you're going to be working with a psychiatrist to try to get that under control. And they may have reductions in insight about having an illness or needing treatment. So they may not see, they may just see this as a bad environmental social situation and not recognize kind of their part in it, how they're interpreting it, how they're dealing with it, or see that there are other outs. So they may not recognize that treatment can help. So we want to educate them about what treatment can do for them. During maintenance, patients undervalue the benefits of treatment and focus on its burdens. It's expensive, it's time-consuming, I got to take time off from work. So if we can make it convenient, that's helpful. And try to work with the person, maybe every 2 weeks, and you have a face-to-face session, and in the middle, on the off weeks or whatever, you have a brief phone call. I don't know how you would bill for that, but try to think about ways to increase their compliance. When you're talking with their family, encourage, educate that psychiatric disorders are real illnesses and effective treatments are both necessary and available. People aren't just going to snap out of it, whether it's cognitive or biochemical or whatever's causing it. There's something that's causing this neurochemical imbalance. So we need to, and it could be behavioral. So we need to address that, or that neurochemical imbalance is probably going to persist. So we need to help them figure out what it is. The role of stressors and other disruptions in precipitating and exacerbating suicidality or other symptoms. So, how can we minimize stressors? And let's educate about what stress does and how it increases anxiety and the HPA axis and impedes sleep and all that stuff. The course of improvement is probably going to be uneven. There's going to be jumps and then plateaus and maybe even a little backsliding, but that's okay. We kind of expect that, and that helps us learn more effectively what the person needs in order to avoid this in the future. Family history of suicide may increase suicide risk, but it doesn't make suicide inevitable. So it's not a hopeless situation. Families need to know how to identify symptoms that may indicate the patient is decompensating, that are specific to that patient. When Jim Bob starts to become suicidal, what does he do? Not everybody acts the same way. They need to know methods for involving the police for involuntary evaluation, or, as one of you pointed out earlier, having them do a well-being check. And I've had that done on many occasions, not a ton, but enough, where a patient wasn't answering the phone and I was concerned, and so we sent law enforcement by to do a well-being check. So know what the laws and regulations are in your area. Talk with your attorney and your supervisor about the limits of HIPAA and confidentiality and stuff. But most of the time, if you have a genuine concern for this individual, you can do a well-being check. And educate about how to react to suicidal behaviors in persons with borderline personality disorder. because sometimes suicidal or self-injurious behaviors are not uncommon in people with borderline personality disorder. We don't want the family to assume that, oh, that's Sally, she's just acting out again. We want them to take it seriously and know how to act in order to diffuse the situation instead of spiral it out of control. Self-injurious behaviors may or may not be associated with suicidal intent. Sometimes it can be a means of releasing endorphins, numbing the pain, the intrapsychic pain, getting control, getting back at somebody by trying to make them feel guilty. There are a lot of motivations. Without having any desire for death, individuals may intentionally injure themselves to express anger, relieve anxiety, generate a feeling of normality or self-control, terminate a state of depersonalization. So if they feel like they're detached from themselves, that may let them feel something, and to distract or punish themselves. Self-injurious behaviors are sometimes characterized as gestures aimed at achieving secondary gains, which may lead to behaviors being downplayed when associated with minimal self-harm. Just knock that out of your brain right now. Take everything seriously. In assessing chronic self-injurious behaviors, determine whether suicidal intent is present. And obviously, if you're working with somebody who's chronically self-injurious, there's going to be a whole clinical plan around that, so you know how not to reinforce that behavior, but how to also give it, due consideration. There's an absence of suicidal intent or a minimal degree of self-injury should not lead the clinician to overlook other evidence of increased suicide risk. So if they're tidying up affairs and saying their goodbyes, even if they're not really hurting themselves significantly right now, doesn't mean they won't. Every act needs to be assessed in the context of the current situation, biopsychosocial. The most frequent lawsuits, settlements, and verdicts against psychiatrists are for suicides. Failure to document suicide risk assessment and interventions may give the court reason to conclude they were not done. So document it, and document your consultations. When you call up, your fellow colleague and say, hey, I'm wondering if you would involuntarily commit on this. For patients who are hospitalized, it's also important to document the aspects of the risk assessment that justify inpatient treatment, particularly when it's occurring on an involuntary basis. So what justifies keeping this person on a 72-hour or however long hold? In documentation, you need to have reference to the reason for the assessment in order to set the context for the evaluation. So why is this person here? Why do we think they're suicidal? The documentation reviews the factors that may contribute to increased shorter-term or longer-term suicide risk. So, the person had ideation, but what made you think that they were really at risk? What risk factors were there? Reasoning processes that went into the assessment, clinical conclusions, and again, consultation. Please put that in there. Changes in the treatment plan should also be noted along with the rationale for such actions. So if they've been in once-a-week outpatient going along, and then all of a sudden they are involuntarily committed or voluntarily committed, their treatment plan's probably going to change. So we need to know why, not just have a sudden treatment plan change, but know why it changed. Interventions or actions that were considered but rejected should be recorded as well. So if you considered hospitalization but decided against it, defend why you did that. Suicide contracts are overvalued. It's not a legal document. It cannot and should not take the place of a thorough suicide risk assessment. An undue reliance on suicide prevention contracts falsely lowers clinical vigilance without altering the patient's suicidal state. And I've seen this when we've had clients on the unit who have been suicidal, and we've had them sign a no harm contract, and we also have them checking in every hour with their moods. But if they willingly sign that contract, I've seen the intensity, that's not the word I'm looking for, but of staff supervising that client go down. So they're like, okay, the person's fine, we'll just check in with them every hour. If the person resists signing that contract and seems to be more resistant to it, then I see staff being more vigilant about watching that person. So it's important not to take a piece of paper and assume it really means much of anything. Crisis intervention is a client-centered and comprehensive. It uses patients' strengths and resources. When people are have suicidal ideation, they are in crisis. Empathy and genuineness are key factors to developing that rapport and resolving the situation. Treatment modalities and settings are based on the client's level of functioning, their dangerousness to self, and the availability of supports and resources. So family supports, but also community resources. And also consider when we talk about supports, and we talked about this a little bit, if they're alone, if they live alone, that's a higher risk setting than if they don't. Documentation is essential throughout the process, not just at assessment, but when you're reassessing, before discharge, when you change a treatment plan, because we want to make sure that we're kind of keeping our finger on the pulse of what's going on here. Pharmacological interventions are used to provide acute symptom relief and enable the patient to focus on psychosocial interventions. It may help them get enough energy to focus on the interventions or reduce their anxiety enough where they can think clearly. All clients have the ability to help themselves, though, and that's what we really want to take away from this. Alrighty, everybody, thank you for sticking with me. Do you have any questions? And yes, Andrea points out a good thing, that a lot of times when people are in crisis, they may have gotten to the point where they have exhausted their family resources, and the family's just like, I don't have any more to give. And sometimes when people are in jail, that's another reason they don't visit, because the family's just like, well, maybe they need some tough love for a while because everything I've done hasn't seemed to help. So we don't want to condemn families for not visiting, or not being as present as social supports as we would like, because we probably don't know what's led up to that. Okie dokie, everybody, have an amazing weekend, and I will see you next week. And yeah, we still have a couple more days in the month, so I'm not going to say see you in March quite yet.